السلام عليكم ورحمة الله وبركاته. أهلا بحضراتكم. وسعيد إن أنا موجود معاكم النهاردة في مؤتمر جامعة طنطا. شكر جزيل لدكتورة عبير على دعوتها لي أنا أكون موجودة معاكم النهاردة. معاكم إيناس زهران من جامعة المنوفية. هنتكلم what is behind. In the era of COVID-19, not every patient with lymphopenia is a COVID-19. We'll start with case 1 of a male patient, 33 years old, from Shpinilkom, worker, married with 2 offspring, had no special habit of medical importance. He was presented to the ER with fever, fatigue, with no chest symptoms. His examination brought free, except for temperature 39. His investigation revealed a TBC show anemia, leukopenia, lymphopenia. Otherwise, blood was normal and chest was free, CRP 24, and he was suspected as having COVID-19 and received the COVID regimen treatment, but without any involvement, and he was asked to make a swab for our PCR for COVID, and it was negative. He was advised to complete his regimen, but the condition became more worse with drowsiness and hallucination. His examination revealed oral and malarish, and CBC was ordered again, which show more drop in hemoglobin, non-cyclomic anemia, leukopenia and lymphopenia, and thrombocytopenia, which is still free, and CRP is negative. ANA and double strand were ordered, and they were positive with urine protein creatinine ratio of 2 and 5 gram protein per milligram creatinine. MRI brain showed vasculitis, and so balsasteroid was given for him with a cyclophosphamide dual regimen, and the patient was improved. So we must search well in a patient with lymphopenia. Lymphopenia, protein energy malnutrition, is the most common cause in the world. And autoimmune disease may be a cause, lymphoma, myasthenia, viral and bacterial infections, some drugs or radiation. So we must search well what is the cause of lymphopenia. In the era of COVID, many patients have a delayed diagnosis because they were diagnosed as COVID-19. However, some of them was a systemic lupus patient, and some of them were diagnosed as lymphoma. We met these patients this year, so this is very important to think well what is is behind and what is the appropriate diagnosis of this patient. Case 2, think positive. Female patient, 42 years old, female from Shohada, housewife, married with 3 offspring, with no special habit of medical importance. She was presented to the ER with severe gastric pain, referred to the PAC associated with vomiting and absolute constipation. Her examination of abdomen, there were tenderness, and surgical consultation were done for her because of the tenderness, vomiting, absolute constipation. Her abdominal ultrasound was ordered, which revealed some edema of the head of bank areas, and CT abdomen revealed diffuse parenchymal enlargement. Amylase lipase were high. CBC show anemia, normocyclomic anemia. Otherwise, the CBC was normal, and ESR was 100. Internal medicine consultation for anemia. By history taking, the patient has a history of arthralgia, so rheumatological consultation was ordered. In history taking, the patient has a history of arthria 2 years ago with non-specific diagnosis and treatment, with a history of recurrent abortion and dry eye and mouth. Non-specific finding in examination: ANA, anti-double-strand DNA, and rheumatoid factor, anti-Rho, anti-Law were ordered, and ANA, anti-Rho, anti-Law were positive, and balsasteroid and azathioprine were given to the patient with the NBO, and the patient improved. We have also as the same patient with the same manifestation, and her ANA and the anti-double-strand were positive and were diagnosed as systemic lupus. In her CBC, there was leukopenia, lymphopenia, and thrombocytopenia, and she was diagnosed as lupus. Balsasteroid also were given, and azathioprine, and the patient improved. So when we have a case of pancreatitis and history taking is very important, it may not be a surgical cause only. We know that pancreatitis most commonly may occur due to gallstones or hyperlipidemia, maybe due to abdominal trauma, but sometimes it may be due to autoimmune disease, and most commonly with lupus and Sjogren syndrome. It may occur due to infection and maybe idiopathic. So we must think positive. Our message is: not every patient with lymphopenia is a COVID-19, and careful observation of the patient with pancreatitis, and some of them may be a presentation of autoimmune disease. So always search what's behind and think positive of your patient. Thank you.